Hi students, I welcome you all to Obstetrics and Gynecology with Mackler. So from this module onwards, we are going to discuss about the surgical management of prolapse, which is the best management in a patient of prolapse. So for an easier understanding, I have divided this topic into various sections depending upon the age group of the patient. So in this module, we are going to discuss about the management of prolapse in reproductive age group female. So here you just focus upon the reproductive age group female alone. Okay? Yes. So let's start with the management of first degree prolapse in a reproductive age group female. So as we all know, always the management of first degree prolapse is a conservative management which consists of perineum strengthening exercises, which is called as Kegel's exercise, and insertion of pessary in the vagina. What is a pessary? A pessary is a space occupying prosthetic device which is going to provide structural support, and it will prevent the uterus and cervix from descending into the vagina, right? So it is going to prevent the chances of prolapse, and it is going to prevent the progression of prolapse as well. So both the Kegel's exercise, which is the perineal strengthening exercise, and along with that insertion of pessary, which is a space occupying device, is the management, conservative management in a patient of first degree prolapse. Clear? Yes. Now moving on to the second degree and third degree prolapse. So when discussing about the second degree and third degree prolapse, we need to take into consideration one important thing. So we have discussed in the previous module that always management of uterocervical prolapse has to depend upon the age and the parity of the patient. Age and the parity of the patient is very important when discussing about the management of prolapse in second and third degree, right? So here we have a patient where she is a reproductive age group female who has not completed her family, which means she is a nulliparous female. So either you can tell she is a nulliparous female or she is a reproductive age group female who has not completed her family. So in this patient, the surgery which is going to be done for prolapse has to be a fertility sparing surgery. So fertility has to be preserved in this patient. Only then the patient will be able to have future conceptions, because she is a female, she is a reproductive age group female with complaints of prolapse, right? And she has not completed her family. So she is in plan to have children in future, right? So in that patient, you cannot do any definitive surgery. You have to do the surgery which has the nature of fertility preserving. So therefore, fertility preserving surgery has to be done in this patient. But then, for doing this fertility preserving surgery, one important condition has to be met. That is, uterocervical length has to be normal in this patient. If the uterocervical length is going to be normal in this patient, then this patient is actually an ideal patient for sling surgery. So what is a sling surgery? So this surgery is based on the fact that the most common cause of prolapse in females is because of the weakened supports of the uterus and the cervix, such as the weakened muscles and the ligaments which are supporting the uterus. So only because of that reason, the uterus is going to be descended from its normal anatomical position. We all know that the ligaments which are supporting the uterus, the most important ligament is the cardinal ligament and the uterosacral ligament, right? A female who is going to undergo conception and she is going to deliver her fetus, and once she is going to attain menopause, after that period, due to all these risk factors, the female might develop prolapse. And all this prolapse is happening because of weakening of the supports of uterus and the cervix. So the sling surgery is based on the fact that you are going to provide the same sort of support which has been provided by these ligaments, but you are going to give this support through artificial tapes. So this is the principle of sling surgery, where a Mercelin tape is used in the sling surgery, which is going to provide the support to the uterus and the cervix in a way which is similar to the support provided to the uterus by the muscles and the ligaments which were supporting the uterus. So this Mercelin tape is going to provide the support which is going to help the uterus and cervix in its normal anatomical position. So the sling surgery can be of two types, where it is anterior sling surgery and posterior sling surgery. This anterior sling surgery is Purandare sling surgery, and this posterior sling surgery is Shirodkar sling surgery. Right, we'll be discussing about each of it in detail now. So what is anterior sling surgery? Anterior sling surgery is the Purandare sling surgery. So as you can see in this image, this is the Mercelin tape, right? The image which you are seeing here is the Mercelin tape, which is basically a tape. So what are you going to do here is that anterior sling surgery means that the slings are attached with the anterior structures. So one end of the sling is anchored to the anterior part of the cervix, right? The major use of this sling is to support the uterus and the cervix. So what I'm going to do is that I'm going to take one end of this sling and I'm going to anchor this one end to the anterior part of the cervix. And I'm going to take the other end of the sling and anchor it to the anterior structure, which is anterior to the uterus and the cervix, which is the anterior abdominal wall. From the anterior abdominal wall, you're going to take the rectus sheath. So what I'm going to do is that one end of the sling is anchored to the anterior part of the cervix and the other end is anchored to the rectus sheath of the anterior abdominal wall. As you can see here, alright, one end is attached to the anterior part of the cervix and the other end of the Mercerin tape is anchored to the rectus sheath of the anterior abdominal wall. Since everything is anterior in approach, it is called as the anterior sling surgery. From the anterior part of the cervix to the rectus sheath in the anterior abdominal walls, therefore it is the anterior sling surgery, which is the Purandare sling surgery. The most important point here is that this Purandare sling surgery is a dynamic sling surgery. Why? It is a dynamic in nature because the abdominal tone of the patient has to be good in order to do this Purandare sling surgery. See, one end is attached to the anterior part of the cervix and the other end is anchored to the rectus sheath of the anterior abdominal wall. So only if the abdominal tone of the patient is going to be good, then therefore the rectus sheath will be power enough to hold the uterus in its normal anatomical position. If the abdominal tone of the patient is going to be altered or it is going to be poor, then therefore the rectus sheath will never be able to hold the uterus and cervix in its normal anatomical position. So therefore, because of the chances that the abdominal tone of the patient might get altered in future, therefore there are increased chances of failure of this surgery. So the success rate of this surgery is actually decreased. And when coming to the complications are less when compared to the posterior approach. So anterior sling surgery, the complications are very less because you are taking the sling right from the anterior part of the cervix and you anchor it to the rectus sheath. So there are no chances of complications of injuring any important vessels or nerves. But then if the abdominal tone of the patient is going to be altered, then the rectus sheath will never be able to hold the uterus in its normal anatomical position. So because of that reason, there are increased chances of failure of the surgery, but the complications rates are less. Is that clear? Increased chances of failure of this surgery. The complications are less. Is that clear? Yes. See, let me show you the image once again. From the anterior part of the cervix, one end of the sling is attached and the rectus sheath, the other end of the Mercerin tape is attached. So this rectus sheath is actually going to provide support to the uterus and cervix and it is going to hold the uterus and cervix in its normal anatomical position. Is that clear? Yes. So now moving on to the posterior sling surgery, which is the Shirodka sling surgery. Alright, posterior sling surgery, which is the Shirodka sling surgery. What you're going to do in Shirodka sling surgery is that one end of this Mercerin tape is anchored to the posterior part of the cervix. Since it is posterior sling surgery, therefore you take the posterior part of the cervix. One end of the Mercerin tape is anchored to the posterior part of the cervix, whereas the other end is anchored to the structure which is posterior to the uterus, which is the sacral promontory. As you can see here, right, as you can see here, one end of the Mercerin tape is attached to the posterior part of the cervix and the other end of the Mercerin tape is attached to the structure which is posterior to the uterus, which is the sacral promontory. So since everything is posterior in approach, it is called as posterior sling surgery, and the sacral promontory is going to give a constant sort of support to hold the uterus and cervix in its normal anatomical position. So since the sacral promontory is providing a constant sort of support, it is a static sling surgery. Since it is providing a constant sort of support, it is a static sling surgery. Whereas Purandare sling surgery is a dynamic sling surgery. Why? Because the abdominal tone of the patient might get altered later in life. If the abdominal tone is going to get altered, then the rectus sheath will never be able to provide constant sort of support to the uterus and the cervix to hold it in its normal anatomical position. So since it is not able to give constant sort of support, unlike the Shirodka sling surgery, Purandare sling surgery is a dynamic sling surgery. Whereas the Shirodka sling surgery or the posterior sling surgery, it is a static sling surgery. In other words, if you have confusion between Purandare and Shirodkar, which is static sling surgery, just remember S for sacral promontory, S for sling surgery, static sling surgery. Clear? Yes. And this Shirodkar sling surgery is the most commonly done sling surgery. The reason is only one, because it is a static sling surgery. Once it is anchored to the sacral promontory and the posterior part of the cervix, this sacral promontory is going to provide a constant sort of support to the cervix and the uterus to hold it in its normal anatomical position. So since it is providing a constant sort of support, therefore Shirodkar sling surgery is the most commonly done sling surgery. But then it has the disadvantages of more complications when compared to the Purandare sling surgery. It is because since it is a posterior approach, therefore when you go posteriorly, there are increased chances of injury to the major vessels, such as injury to the mesenteric vessels, injury to the genitofemoral nerve, injury to the ureter, and in cases of Shirodkar sling surgery, there are increased chances for sigmoid colon obstruction as well. So what are the chances of complications? Injury to genitofemoral nerve, mesenteric vessels, ureteric injury, sigmoid colon obstruction are all the complications which will be seen in patients who have been undergone Shirodkar sling surgery, because it is a posterior approach sling surgery. But then the most important point is that all of these complications are more on the left side when compared to the right side. All these complications, injury to genitofemoral nerve, mesenteric vessels, ureteric injury, sigmoid colon obstruction, all these injuries are more common on the left side when compared to the right side. Right? So for that reason, one important update was done later, which is called as the composite sling surgery. So what is a composite sling surgery? Is for the right side, you're going to do Shirodkar sling surgery, and for the left side, you're going to do Purandare sling surgery. Why? Why composite sling surgery? Right side you are doing Shirodkar and left side you are doing Purandare. It is because if you do Shirodkar on the left side, there are increased chances of injury to ureter, sigmoid colon obstruction, injury to the mesenteric vessels, injury to genitofemoral nerve. So only if I do the surgery on the left side, all these complications can arise. So I'm going to do the Shirodkar surgery on the right side, and there will be no complications. On the left side, I'm going to do this Purandare sling surgery. So that is the reason for this composite sling surgery. Clear? Composite sling surgery. And one of the outdated posterior sling surgery is Khanna posterior sling surgery. Where one end of the Marcelin tape will be attached to the posterior part of the cervix, and the other end of the Marcelin tape will be attached to the anterior superior iliac spine. Right? Let me write it here. One end of the Marcelin tape will be anchored to the posterior part of the cervix, since it is posterior approach sling surgery, and the other end will be anchored to the anterior superior iliac spine. But then it is an outdated posterior sling surgery. The most commonly done sling surgery nowadays, it is only Shirodkar sling surgery. Is that clear? Shirodkar sling surgery is the most commonly done sling surgery. Clear? And this image, if they given you exam, you have to identify it, right? As you can see here, it is an anterior approach, anterior part of cervix, rectus sheath. It is Purandare sling surgery. Clear? Yes. Now, posterior part of the cervix, posteriorly situated structure, sacral promontory. So therefore, it is the posterior sling surgery, which is the Shirodkar sling surgery. Clear? Yes. Now, this is a very important table, right? You can just take a screenshot if it is required for you, but then it is very important. So let's discuss about it now. So here I have mentioned female of reproductive age group female or a nulliparous female. If her family is completed and if her family is not completed, what are you going to do? So a female of reproductive age group or a nulliparous female whose family is not completed, you need to check the uterocervical length. If the uterocervical length is going to be normal, you can do the sling surgery. Like I told earlier, if a family of a reproductive age group female is not completed, you check the uterocervical length. If the uterocervical length is normal, you can do the sling surgery. But then, if the uterocervical length is not normal, it is increased, means you cannot do the sling surgery. But then you have to do a different surgery, which is called as Fothergill's repair. Similarly, a female of reproductive age group a female of reproductive age group, not an nulliparous female, but then a female of reproductive age group whose family is completed. Reproductive age group female, but her family is completed, and the uterocervical length of this female is increased. So family is completed, she's a reproductive age group female, but the uterocervical length is increased. So very well you can do Fothergill's repair in this patient. Is that clear? See, it's very simple. Reproductive age group female, family is not completed, check the uterocervical length. If it is normal, do sling surgery. If it is not normal, if it is increased, do this Fothergill's repair. Likewise, female of reproductive age group who has completed her family. She has completed her family, and along with that, the uterocervical length is increased. So any female of reproductive age group who has completed her family and the uterocervical length is increased, in such females you have to do Fothergill's repair. Now all about Fothergill's repair will be discussed subsequently. So what is Fothergill's repair? So Fothergill's repair is basically non-fertility sparing procedure. It is non-fertility sparing procedure, whereas sling surgery is fertility sparing procedure. So there are two important steps which has to be done in Fothergill's repair. So one is amputation of the cervix. What is amputation? You are going to remove the cervix. And second is plication of the cardinal ligament. What is cardinal ligament? Transverse cervical ligament or the McEnroe's ligament is the cardinal ligament, which is the most important ligamental support of the uterus. So what are the two steps of Fothergill's repair? One is cervical amputation and the other is plication or folding of the cardinal ligament. Now you may have the doubt that why it is done actually, what is the use of this procedure? Let me show you here. See, as you can see in this image, this ligament which is situated laterally, this is the cardinal ligament. And here, step 1, what are you going to do is you're going to amputate the cervix. So this is the cervical portion and you are going to just amputate the cervix. Just amputate the cervix. If you're going to do amputation of the cervix, what is the use of this amputation? So if you're going to do amputation of the cervix, then definitely whenever you do some surgery, there are increased chances of adhesion formation, right? So therefore, once you remove the cervix, there are increased chances of adhesions formation between the uterus and the vagina. So once adhesions are formed between the uterus and the vagina, then therefore there are decreased chances for this uterus to prolapse into the vagina. Is that clear? You remove the cervix, right? I'm going to remove the cervix. So since I remove the cervix, there are increased chances of adhesions between the uterus and the vagina. So because of these adhesions, the uterus will never descend into the vagina. So the chances of prolapse in this patient is actually decreased. Clear? Yes. So it is the major reason for this cervical amputation. The cervical amputation is basically done so that adhesions will form between the uterus and the vagina, and therefore the uterus will never descend into the vagina. Now second, what is plication of the cardinal ligament? As you can see in this image, this is the original position of the cardinal ligament. But what I'm going to do here is that this cardinal ligament will be attached to the pelvic side wall here. Now I have to remove the other end of the cardinal ligament from the pelvic side wall. On both the sides I'm going to remove it and I'm just going to fold it. I'm just going to fold the cardinal ligament. See, cardinal ligament is the most important ligamental support of the uterus, right? It is the strongest ligament as well. Since it is the strongest ligament, I'm going to remove this ligament from the pelvic side wall and I'm going to just fold this cardinal ligament. I'm going to just fold this cardinal ligament over the uterus. As you can see here, I have just folded the ligament. So since the ligament has been folded towards the uterus, it is going to hold the uterus in place and this will prevent the chances of prolapse of the uterus into the vagina. So therefore, plication or folding of the cardinal ligament is basically done in order to prevent prolapse of the uterus and cervix into the vagina. So that is the basis of this Fothergill's repair. But then the disadvantage of this Fothergill's repair is cervical amputation. You may think, what is the disadvantage? See, once you're going to do amputation of the cervix, there are chances of adhesion formation between the uterus and the vagina. And then the uterus will never descend into the vagina. But then, if she is a reproductive age group female who has not completed her family, if you're going to do the surgery in a patient who has not completed her family, it is going to be disadvantageous to that female. Why? It is because if you're going to remove the cervix, it is going to result in cervical incompetence and cervical stenosis. The cervix is going to be incompetent. And once the cervix is going to be incompetent, if that female is going to conceive later in life, then there are increased chances for preterm labor in this patient because the cervix is actually incompetent. Because of cervical incompetence, the patient might deliver the fetus very early in her life, right? So for that reason, because of cervical incompetence and stenosis, this Fothergill's repair is not done in reproductive age group female who has not completed their family. So Fothergill's repair is ideally done in reproductive age group female who has completed their family and the uterocervical length is increased. So for that came this Shirodkar modification of Manchester surgery or Fothergill's repair. So this Fothergill's repair was then updated by modification, which was Shirodkar modification of Manchester surgery or Fothergill's repair, where the procedure of the Shirodkar modification of Manchester surgery is, instead of both these steps, you just avoid the first step, you avoid the cervical amputation step, and you just do the plication of the cardinal ligament. You only do this step, you avoid the cervical amputation in Shirodkar modification of Manchester surgery. So here you are going to just fold the cardinal ligament, folding of the cardinal ligament, which is plication of the cardinal ligament is going to be done. So this strongest cardinal ligament is going to support the uterus and it will prevent the uterus from descending into the vagina. So because of that reason, this procedure can also be done in females desiring future conception. Why? Because cervical amputation step is avoided in Shirodkar modification of Manchester surgery. By you're just doing the plication of the cardinal ligament in this procedure. So since you do only the plication of cardinal ligament and you avoid the cervical amputation, this surgery can also be done in female who are desiring future conception. But then this is not actually done very frequently, because in reproductive age group female who wants to desire future children, the most commonly performed procedure is the sling surgery, the Shirodkar sling surgery, which is the posterior sling surgery or the static sling surgery. Is that clear? Yes. So regarding the management of prolapse in reproductive age group female, the surgical management, it has been described in a very detailed way and in a very pictorial way, I hope. So in case if you have any doubt regarding this surgical management of prolapse in reproductive age group female, you can write to me in the Gmail Mackler handle so that I can reach out to you as early as been possible. And please don't forget to subscribe to this Mackler YouTube handle so